Yeah, so certainly it's really, critical to think about in individual patients how we choose and then sequence different JAK inhibitors in the United States. Of course, we have 4 FDA-approved JAK inhibitors, and so we have in a very good way we have multiple options to choose from. But that certainly can make it a little bit confusing and complicated in terms of which patients, for whom that we might choose one versus another. And I think from my standpoint, there are a number of important factors to take into account, and it's the combination or mix of those factors that leads me to choose which agent to use and when. For example, in the setting of many of the common issues in patients with myelofibrosis, they really relate to constitutional symptoms, splenomegaly-related symptoms, and the presence of cytopenias such as anemia and/or thrombocytopenia. So, a good example is, for instance, a treatment-naive patient for whom their spleen is very large and causing a lot of symptoms, and they have other prominent symptoms, and let's say their baseline blood counts are relatively preserved. That is where historically we might typically use Ruxolitinib as our first choice. And that continues to be, I think, a logical option in that setting. In other patients for whom the cytopenias are more predominant, and that may also be in the setting of not having quite a severe spleen-related and other symptoms, there is where some of the other JAK inhibitors in particular, I think, become really good choices. So, for example, Momelotinib, or in the setting of severe thrombocytopenia, Pacritinib, and this could be most commonly in the second or third line setting, but there are reasons why for those different factors you might choose one or the other in a different order.